Okay. Well, thanks, folks, for joining us today. I'm here with Dr. DiClemente. My name's Dr. Yavorski. We both work for Chronos and Prophase. Today we're going to be talking about placebo and placebo response in clinical trials. And we have some slides for you. We're not going to take too much of your time this morning or this afternoon, depending on where you're calling in from. I'd like to start with an apology for the More Than a Feeling Boston glam rock 1980s reference here, but we thought it was interesting to get it started with this idea that placebos can actually result in something that's just more than an actual feeling. There's real physiological effects. So let's jump right in. Let's see here. Next slide. So the etymology of placebo comes from the Latin placere, to please, and I've seen it translated as I shall please as well. And it's something that does come up in clinical trials, this idea that patients will sometimes want to please the clinician and perhaps report that they're doing a little bit better than they might be actually feeling. In this slide, I thought this was very interesting. A lot of folks might have heard about this study. It came out a couple years ago, and it was actually an economics study entitled Marketing Actions Can Modulate Neural Representations of Experienced Utility. So what they did here was kind of a blend of neuroscience and economics. So this idea of experienced utility in economics is really thought to be about the actual intrinsic properties of a particular good. So if you have soda, it's really about the compounds present in that soda, and that's going to be the experienced utility of that good. Now, what they're looking at here, they had their fMRI set up, and they looked at people's response to wine. And they did a pretty sneaky thing. They picked a couple of different Cabernet Sauvignons, and some were very cheap, probably Trader Joe's Charles Shaw, very cheap, $2 Chuck, on up to a $10, a $35, a $45, and a $90 bottle. And what they did is they randomized it and then told people that the $5 bottle was the $90 bottle, and so on and so forth. And as you'd expect to a certain extent, people preferred subjectively the $90 bottle, even when it was really the $5 bottle. But what was more interesting in this particular study was that these participants' brains were being looked at using the functional MRI, and areas in the frontal cortex associated, prefrontal cortex associated with pleasure were actually activated more when people thought that they were drinking the $90 bottle of wine, which I thought was very interesting in thinking about placebo response in general. Okay, this is kind of from the history of talking about placebo response. There was a patient back in the late 50s who had a fairly advanced form of cancer. Cancer treatment then wasn't so advanced, but he had heard about this compound called crebbiothin, which I'm assuming derives from the Krebs cycle. I'm just guessing there, but it was actually tested on horses, but they had some promising responses with it. And so he asked his doctor to administer it. He had only a couple days to live, and they figured, why not? This was, I guess, before the days of medical ethics boards and that sort of thing, so they just gave him this drug that wasn't approved. And much to their surprise, these tumors that he had were much reduced over several months. It was a pretty astounding result. However, after a couple of months, this patient unfortunately read that this compound had been in some trials and that it really showed no efficacy. And when he stopped believing that it worked, it stopped working and he actually died. So some of the power of placebo there. So there can be real change with fake trials. There was a recent study, Tor Wager up at Columbia, has shown that in brain imaging studies that placebo can actually result in real analgesic effects that are similar to using actual opiates, which is just astounding. He did a lot of work with not only pain studies, but with irritable bowel syndrome, and found just really incredible results with using placebo. This slide called Great Expectations. Now this was a study done with Parkinson's patients, and really incredible results here as well. What they found here was that when they gave placebo, there were real dopamine release in the regions of the striatum that are associated with this, and they showed pretty significant results here that just giving the placebo was nearly as effective as giving L-Dopa to these patients with Parkinson's disease. Pretty fascinating. Just as a sidebar there, some of the people treated with L-Dopa, as many of you probably know, experience psychotic symptoms, L-Dopa-induced psychosis, and so certainly not a fantastic side effect there using that drug. All right, let's move on. Okay, so when we talk in clinical trials about separation from placebo, what do we actually mean? What we mean is that in a lot of these trials, in fact most of these trials, we give folks a placebo, and that's to establish a sort of baseline of what could be expected to occur over time, all things else being equal. This slide is actually from an escitalopram study, and you can see very clear separation from placebo, and this is in terms of MADRS scores, the Montgomery-Åsberg Depression Rating Scale. And at the endpoint, we have very clear separation from placebo. Keeping in mind, though, if we look very closely at this, this is only about a 4 or 5 point difference in the MADRS, and as most of you will know, it's a 10 item scale, and 4 or 5 points could be very easily made up just with a couple of misconceptualizations by raters. Okay, let's move on. Also, I just wanted to briefly mention here what a failed versus a negative trial is. I know we throw these terms around quite a bit. And just to remind folks that a failed trial means that there was a failure to separate from placebo. So if we look back previous slide, those lines would be very close together, if not exactly the same. And in some cases, it's even worse when that pink line is above the blue line when the placebo does better than the drug. That's what we don't want. Okay. And then a negative trial is where none of the treatments show superiority. So basically, the patients did not get better in either the placebo condition or the drug condition. So in the types of trials that we're involved in, not just involved depression and schizophrenia trials, but looking at the placebo response rates here, it is really astounding. In one study, Walsh et al. Back in 2002 found that the placebo response rate was over 70% in some cases. So I'll get to what that really means in just a moment in terms of sample size and power in the study. There's that kind of placebo response in depression trials is a big problem for us. Schizophrenia trials, it's even higher, which really seems incredible, especially when you think of the very, very serious nature of schizophrenia and that you'd expect abatement in psychotic symptoms really to only occur in the presence of an active compound. Okay. Dr. DiClemente, do you want to say anything about this particular issue? Nope, he may have dropped off. Okay, well, we'll go ahead and move on here. Oh, so Fava, Evans, Dorer, and Schoenfeld. This is Maurizio Fava. He is quite active in this area. And some of the contributing factors. Oh, you're there.
I couldn't unmute my phone. I'm so sorry.
Okay, no problem. No problem.
Going back to the topic that you were covering, I think it's important to think about this in terms of exposure to drugs from the patient perspective. So if you manage to lower the sample size, somehow there's a benefit of the patient regarding the need of less patients to set up the next trial.
Yeah, that's right. That's a really good point, and we're going to cover more of that in terms of reliability. But it's not only that decreasing the sample size would be, more resource or less resource intensive for sponsors, but really there's an ethical issue there about exposure of patients to, potentially dangerous study drugs. So yeah, that's an excellent point. Okay, now some of the things that Maurizio Fava and his group have talked about as contributing factors to placebo response are some of the things that Kronos and Prophase really work hard to address. They identify the issue of diagnostic misclassification. This is a huge issue. At recent conferences, we've talked a lot about this idea of getting the right patients in, making sure it's the right diagnosis before we administer these severity measures during the trial itself. Again, issues concerning inclusion, exclusion, getting that right person, and then the outcome measures, their sensitivity to change. There's certain items in the MD, for example, that we know are more sensitive to change. The Beck and the Meyer identified items more sensitive to change than some of the other items in the HAM-D. We know that certain MADRS items are more reliable and more sensitive to change than others, and equally in the PANS, YMRS, and a range of other instruments. Measurement errors, of course. Yes?
Dr. one thing that we discussed a couple of weeks ago regarding one of the works that Fava did in regards to placebo, remember that they did a study where basically they did the first run of randomized placebo patients, and they got rid of all the placebo responders, and then went back and used the remaining of the patient sample and redid the study. And what they discovered was that they still had a lot of placebo responders, that they were in different active treatment arms that were undetected. So this point of the right patient sometimes it's clear that we're still not sure what the right patient means in terms of when they are reacting to treatment or not.
Yeah, that's a really good point. Yeah, I think that's an excellent point, especially, we can certainly have the diagnostic criteria met for schizophrenia or bipolar disorder or depression, and we can still have a placebo responder, so that's a really excellent point. So it's not only about getting the right patient in, but also whether or not those patients respond to placebo. And we know that even wine tipplers are placebo responders in many cases. So just moving on here quickly, poor quality of data entry and verification, that's a pretty simple thing to correct. Some of the stuff that we like to talk about is the patient and clinician expectations about the trial. And this really can be reduced through good training and also good data monitoring. And we'll talk more about that in just a moment. Dr. DiClemente, anything further that you wanted to add about these issues about placebo response?
Good point.
Okay, I'm gonna move on then. All right. So why should we care? And this goes back to the idea of the sample size. So if we know that there's going to be a certain percentage of your the patients that you recruit for this study that are going to be placebo responders, we know that we have to increase the sample size by a proportional extent to demonstrate similar statistical power. Most studies are powered at 0.80 or higher, and if we hold power constant, we know that we'll have to have either a certain reliability or a certain sample size in order to maintain that. Okay. So, slide here. So if we have more reliable assessment procedures, we can really reduce sample size requirements. As we said before, Dr. DiClemente pointed out there's an ethical reason to do this so that we don't expose patients unnecessarily to potentially dangerous compounds. But also there's a resource issue here as well. If we can reduce the sample size, maintain power and reliability, then the whole thing is much more efficient. Andrew Leon up at Cornell has been working on this for a while and has shown pretty clearly that if we can get good reliable assessment, and the way that he's determining reliability there is in terms of interclass correlation coefficients, then we can decrease the sample size. All right, next slide here. So what can we do about this, really? Well, the factors involved are really the patient and the rater. And some patients can be placebo responders and genetically predisposed to respond to treatment. And there may, however, be patients who simply want to please the clinician. And if we go back to our etymology of placebo as the Latin placere, to please, it kind of makes sense. And for those folks that are listening that work in clinical practice, you run into these patients occasionally that after 3 visits, they're telling you that they're really feeling great, and they don't really think that they need to take medication anymore because they feel fine, when really the drug couldn't have possibly started to work, although there are some drugs that are more fast-acting. Also here, there's the rater factor. It's been shown over and over again, really, that raters that are too therapeutic in their administration of these instruments may exaggerate the placebo effect. It doesn't mean that we have to be Mr. Spock in administering these scales, but we should try to mitigate this idea of being too therapeutic so that we don't provoke this response from patients. All right. And also here important to note is it's the rater, it's the patient, but placebo is not administered without context. They're in a clinical trial. There's expectations all around with patient, with the rater, that there will be some sort of effect. And, you know, I was joking a bit here, but Tic Tacs, essentially sugar pills, would be a lot more popular if they, every time you took one, you felt much better. All right. So here I'd like to talk about something called the Rater Applied Performance Scale. We had originally called this the Kronos Rater Applied Performance Scale, but then realized that that acronym was probably not a good one to use. And this is where raters are assessed on a range of factors related to scale administration, things like rapport, adherence, follow-up, those types of things. And rapport here would really include being overly therapeutic with patients. And Dr. Feig and his group at Research Training Associates in Colorado years old showed this pretty clearly. If you look at this slide and look at the poor technique versus good technique, and this is assessed through these RAPS dimensions, people that had higher RAP scores, which means that they scored better, so they adhered to the instrument, they asked good follow-up questions, clarified where appropriate, and were not overly therapeutic, we get much clearer separation from placebo in the group considered to the left and the group considered to the right. Albeit, you know, not to be too critical of this study, but it was a fairly low sample size, so we should certainly proceed with caution here. But it does stand to reason that people that are administering these scales in a more research-oriented fashion are going to, with any luck, get better results here. So training and maintenance, good RAP scores come from really comprehensive training and ongoing data monitoring to make certain that best practice is maintained over time. So ProPhase provides rater training. Some of the things that they do that I think really show excellence are not simply providing didactic sessions with raters, but individual one-to-one applied training. And what that means is that you have an expert clinician on the phone with a mock patient and then the rater, and the rater is asked to do an interview, and they're assessed on these RAPS domains. In order to, this is one of the criteria now to rate on some studies, is that raters will have to pass applied training. And I think it comes from a recognition that really reading from a video is not always adequate for making certain that people are going to perform well. And of course, going on from the applied training, people can be up to snuff at the outset, but may revert to their previous behaviors as time goes along. And that's where data monitoring comes in. I think a strong data monitoring program is really essential in clinical trials to reduce rater drift, to make sure that raters are continuing to conceptualize items correctly, and that we get the most reliable and valid data. Dr. DiClemente, you want to say anything about this? I know that we've chatted a lot over the years about these particular issues.
Can you hear me now?
Yeah, I can hear you.
Okay, good. I was trying to talk before, but you couldn't hear me. Regarding the applied training, I think it's important to consider the validity of how a reader is conducting the interview, which has been something that not everybody was paying attention in the past years, and the only consideration was being using readers that were certified, and by certified meant a person able to score a video. That didn't go well when you start discovering that they didn't pose the right questions, that there were readers that were taking shortcuts, or maybe readers that they weren't even trained to conduct the interview itself. Maybe they're psychiatrists, they know very well what the symptoms are, but that doesn't mean that they have the skills to collect the right information. So I think that that's the value of this method of applied training, when you can actually make readers understand what are the right follow-up questions to pose, and what are the different symptoms that you are assessing, and not, I don't know, if you use the PANS as an example, I've seen readers asking patients how many voices they're hearing when they're talking about hallucinations, and that's something that is related to DSM-4, but not related to the PANS itself. So it's important to go over these interviewing techniques in order to make them understand what is the information that they're looking for.
Exactly. I think that's really a critical point, is that often in these trials we're working with psychiatrists or clinical psychologists that are very, very experienced folks. They've been working in their area for a long time, and really feel like if they do a good, solid clinical interview, they can just fill in the PANS or fill in the HAM-D. It doesn't really matter. And what we try to get across is, yes, we respect and appreciate that you're an excellent clinician, but what we're really trying to do here in these studies is detect change over time, in this idea of detecting signal and separation from placebo. We're only really going to get reliable and valid data if we have clinicians doing the scales in basically the same way, in a reliable way, and not doing it in their idiosyncratic manner. We've come into contact with a lot of readers over the years that say things like, well, the way that I do the PANS is this. And that's fine. And I think if they're in a more academic research study, or they're in their own practice and they want to do it that way, that's fine. But for clinical trials, I really think it's essential that everybody is singing from the same hymn sheet, really. Okay, let's move here. So there's some research that we did. It's a little bit of a sidebar, just kind of interesting stuff. We got some unblinded data and ran it through the algorithms that Kronos has. These algorithms are sort of based on the logical relationships that exist between items in a number of scales, and in this particular study it was the PAN, so we're looking at binary relationships as well as factorial relationships. And we found that the presence of certain patterns of these inconsistencies was relatively strongly predictive of placebo response, which was pretty interesting. We're waiting to get a larger set of data. As you can see, this is a pretty small data set to confirm these findings, but it is promising and it is pretty interesting. And I think the idea of placebo response, especially as it's being studied with some of the neuroimaging stuff we've discussed earlier, is really, really fascinating. So just to kind of wrap up this idea of placebo response, it's pretty well demonstrated It is a barrier, I think, to adequately powering clinical trials. And I think one of the ways that we can address it is through maintaining reliable and valid ratings. But as we saw in the information from Dr. Fava and as Dr. DiClemente pointed out as well, we're not always going to be able to catch everybody. So maintaining good ratings to detect placebo responders if they are there, I think is going to be important stuff going forward. Dr. DiClemente, any concluding thoughts here before Hannah opens it up
no,
to
I think that
questions?
I think that the point is well made, and you're absolutely right. You know, this is what we have so far to try to minimize the placebo effect in clinical trials. There are so many other components that affect this topic that we cannot even control. Like, for example, the personality of a rater. You know, if you have a rater that is very popular, or some PIs that we see that are very popular, that they are nice, and sometimes patients feel pressure of responding to treatment because of the personality of the people, and it's something that is impossible to control. So I think that what we can do the best is to try to get better ratings and try to put all the raters on the same page regarding what to score and how to collect the information.
Yep, I agree, and I think in the absence of a definitive biomarker for placebo responders, which I don't know that there would ever be one, but certainly possible, I think this is one of the best things that we can do at the moment. So great, let's see, Hannah, if we could open up for questions. I think I can see the other screen there. Okay. All right, so some questions are asked about whether or not, oops, I think I've broken the slide presentation now. What else we can do about placebo response through surveillance. And again, just to echo what Dr. DiClemente said, is looking at the raters once they're in study to determine, again, if they're conceptualizing items correctly and whether or not they are doing the scales really according to how they're written. Things like clarifying whether symptoms were present in the past 7 days and those types of things. Okay, so I don't see any more questions. So thanks everybody very much for participating today, and it's been a pleasure talking to you about these things. If you want to email myself or Dr. DiClemente, I can send on my email to Hannah, and feel free to get in touch. So thanks very much, Dr. DiClemente. Thanks for joining us today. And take care. All righty. Bye-bye.